Hi everyone, and welcome to another episode of Meet the Experts. I am delighted to introduce you and the world to Lauren Mansell, who's a fellow faculty member on Herman&Wallace and who's developed a really intriguing new course all about how we as pelvic health practitioners can incorporate awareness of trauma into caring for our patients better, but I think also practicing good self-care as well, which often gets overlooked. And I think is often an area that I think can drive a lot of compassion fatigue and burnout. I really think that trauma awareness and pelvic health need to go much closer together than maybe they are at present. We know that the pelvic floor muscles are such an emotionally responsive part of the body. But before we jump in, I'm going to get Lauren to introduce herself and just tell us a little bit about your background.
Hi, I'm Lauren Mansell. I work over at University of Chicago. My specialties include bowel, bladder, sexual function, and
all good stuff.
I only treat oncology, and I have a strong trauma background.
Nice. So, in terms of this course particularly, how would you define trauma, Lauren?
So, trauma is when there is a loss of potentially a loss of life or a loss of limb function that you've either experienced, that you've witnessed someone experiencing, which is very, that's what we see day in, day out, is possible loss of function. And additionally, loss, near loss, or experiencing catastrophic experiences.
So would it be fair to say as well that maybe trauma is whatever you think it is? I mean, much like pain is whatever you think it is as well. What one person experiences as trauma might not have as deep an effect on somebody else. So there is that element of subjectivity to it.
Absolutely, and that's why it's been very difficult for the American Psychological Association to come up with actual, the terms and the definition is so varied and it's under so much argument. They're really trying to figure out how to describe trauma, because what is traumatic to me may not necessarily be traumatic to you. Our experiences coming from both our physiology and our background and even our culture can influence the effects of trauma onto us.
Well, yeah, I mean, I think there's a direct parallel, isn't there? Because if we talk about the definition of pain from IAS, it's an unpleasant sensory and emotional issue as well. So there's a little blurring of the line there. But I think particularly when we talk about pelvic health, and the trauma that patients go through, I think general trauma, in PF1, we talk a lot about waking the tiger, and Levine's work around that as well, and the somatization of stress and trauma. How can trauma affect the autonomic nervous system? Because that's an area of huge interest, I think, to a lot of folks, and an area where there's some good research happening at the moment.
Absolutely. So Levine actually brings up Stephen Porges. He's got the polyvagal. So when I first started working in trauma and the autonomic nervous response, so you've got parasympathetics, rest, digest, and heal. You've got sympathetics, fight, flight, or fright, which, I mean, every woman or pelvic patient that I see is usually coming in at some level of sympathetic. The freeze component always confused me, and freezing can be a huge indication of how someone deals with trauma. The patient that is least likely to have processed their trauma has had a freeze or a dissociative experience, or can have had a freezing or dissociative experience. So it's those patients who I think are at the biggest, they're the biggest need to have a trauma-sensitive treatment, and also needs to have a very big army to help them, because when they freeze on our table and then they start to process, it can be scary both for the practitioner and for ourselves and the patient.
Yeah.
So back to, sorry, polyvagal, I just went off. So there's sympathetic, parasympathetic, and then what do we do with the freeze? Some neurologists have put freeze in parasympathetic. Other neurologists have put freeze in sympathetic, where Stephen Porges has actually said, there's a more prehistoric pathway on the vagus nerve. It's on the dorsal aspect of the vagus nerve that has really this protective freeze dissociative aspect to dealing with trauma. And that my patients that don't fare as well, they're the ones that haven't processed or haven't had the words or haven't even come to terms with the trauma that they've experienced, whether or not it's, you know, through their treatment or through experiences they've had prior to our treatment.
I think as well, you know, obviously there's the trauma of something that happens personally to you. For example, in an oncology situation, or if somebody has a traumatic birth experience, either physically or psychologically. But I think even the effects of a traumatic event. I taught in New Zealand fairly recently, and you know, there's still some ongoing issues after the earthquakes that happened in Christchurch years ago. And there's lots of research looking at post-traumatic stress and how that can manifest in people who are still living in Christchurch and still going through a huge amount of rebuilding. So the reminders are there all the time. And, you know, when I taught there, normally at the start of a course, and you know this as well as I do, you know, we do our housekeeping announcements, you know, the fire exits. But when I was in New Zealand, and in case of an earthquake, this is what you need to do. So it's front and center, and you can just see that kind of, you know, underlying tension almost. And I think it's going to be really interesting just to, you know, we can zoom into the individual, but also zooming out to what's happening environmentally and socially and culturally for patients as well. How then, you know, how can working with traumatized patients in whatever clinical setting, how can that affect therapists and their caregivers? I mean, what sort of manifestations of boundary blurring can occur?
So you're talking about secondary traumatization or compassion fatigue, and it's very real, and it's very, what I have to do is I have to take an inventory every day of how I'm feeling and how I'm processing. There are just days that you get in the car and you have to cry, or you have to scream, or you have to get angry, and you have to process it, because just absorbing and just hearing what we experience through our patients is traumatic to ourselves.
Yes.
It's a very, very important. I can only treat as well as I am well. So if I'm not taking my care, if I'm not taking care of myself, I mean, it's going to actually be harmful to my patients, because there are going to be poor boundaries. There are going to be, if I'm not healthy and strong, I'm not going to be able to care or identify and care, not in the way of like how I feel towards someone, but literally the delivery of my treatment is not going to be as good if I'm not in a good space.
In a good place physically and mentally. And you know, I'm thinking, you know, of specific patient scenarios. So whether we're talking about oncology patients or perinatal patients, or even patients who've undergone sexual trauma or sexual assault, what sort of pelvic health repercussions are you seeing with these patients?
So high tone across the board, very, very, very high tone. A lot of guarding and a lot of the vulvodynias. I mean, it's so oniony. Yeah. So trigger points, weakness, but weakness from that high tone. So they are patients who need manual therapy, and then also the manual therapy is very difficult because it can be triggering. So having, you know, that rapport and that relationship that you're building with your patient, and processing and talking through it all. Like, we're not, as a pelvic therapist, I am not there to treat their trauma. I am there to treat the effects of their connective tissue and their function. If they end up being able to process on their own in a safe place, possibly with other friends or other people brought in, possibly just with safe boundaries, I'm 100% okay with that. But again, my treatment or my scope of practice is to fix their functional deficit, deficits that they're having.
So, you know, obviously in an ideal world, you know, I think that the future of healthcare is going to be this multidisciplinary integrated approach, you know, where we've got the physical therapist, we've got, you know, maybe a nutritionist, a meditation instructor, maybe someone who can deal from a psychological, you know, a therapist perspective. But in reality, I think for a lot of pelvic health therapists, you know, we tend to work in isolation. So I think I wonder if you could speak to, you know, the difference between trauma-specific care and trauma-informed awareness when it comes to working with patients who've been through these levels of trauma?
The trauma-informed is when you have really good background of the physiology and the awareness of what that trauma survivor has gone through. Mm-hmm. Whereas a trauma-specific intervention is going to be a more psychologically addressing, this is more of like what Levine does, or what a psychologist or social worker would be working with on specifically processing their experiences. Whereas the trauma-informed treatment is, I am very aware that the patients on my table can respond in very odd, obscure, any way that may not be comfortable to me with my own personal backgrounds or my expectations of what I think my patient should respond as. So knowing that their response can be really across the board, just a very, very incredibly varied. And then having that non-judgment, that ability to say that I believe you, I trust you, you're okay, you're safe, keeping myself safe at the same time, and just kind of being aware that there are times where I'm reassuring someone that they're safe and I'm actually like, oh my gosh, this is really scary.
Yeah.
So that's trauma-informed, is really knowing that these patients can respond in ways that their body is trying to protect them, or their mind is trying to protect them, but it's not in a irrational, it's not a rational behavior that we would expect to see, and just kind of knowing that and expecting the unexpected when you're treating these patients.
And knowing when and how and who to refer on to as well.
Absolutely.
And I think,
I'm very lucky.
Please go ahead.
I am very lucky to work in a very, very multidisciplinary, so I can bring in sex therapists, I can bring in psychologists, social workers. So I am incredibly lucky and grateful, but I can also say that we can build the team even outside of working in a hospital academic level. There are many places in our, we have people coming in from actually all over the country. Mm-hmm. India, I've prepared people from India, just all over the country, where I have to rely on local pelvic floor physical therapists. And so giving them a resource of me, and also kind of letting them know, like, who is there locally. Please reach out to your CASA, your Coalition Against Sexual Assault, your birthing classes, your local hospital. Find the people who are also passionate about supporting these patients. Become their friends, let them know, here's my cards, this is what I can do. Maybe do some co-treats. It's a lovely way of either visiting their office or inviting them to come to your office, especially with a patient who needs extra support.
Yes.
There's no substitute with providing the best support that you can for that patient who is incredibly scared and really intimidated by coming in for treatment.
Absolutely. And I think, it raises the point, doesn't it, that, we have to remember that there's a whole person sitting in front of us. It's not just a pelvic floor or a vagina or an anorectal canal or a cervical cancer patient. There's a whole person there with a life and with a journey that they're on. And what can we do to really serve them well? But taking care of our own boundaries as well, and practicing good self-care and modeling good behavior for our patients too, which is something that some of us do struggle with. So I think, sometimes when we talk about issues like this, a couple of accusations get leveled that, oh, we're trying to be psychologists, or we're trying to be, cognitive behavioral therapists, and it's outside of our scope. But I wonder if you could just speak to the importance again, maybe, of just being psychologically informed, because this is such a sensitive and loaded area of the body. And again, we know that every thought that we have is going to have a physical reaction, be it from neuropeptides or the autonomic nervous system, but even just the direct effects on our digestive system, our ability to control elimination, our sexual function. So how can we stay within scope, but really embrace what we need to know to serve these patients well?
So the most important is having that rapport and that relationship, and the boundaries, and really what the goals of treatment are. So when my patients come in, I am very clear. I am a physical therapist. I happen to have a background in mental health and trauma, but my role and what I am doing is working on bowel, bladder, sexual function, whichever way, shape, or form that takes on. With having it, it is so new, this trauma-informed care, and it's so big, it's bubbling. I think this is going to be in the next 5 years, something that we're going to be like, wow, can you believe we actually used to practice without having a very high trauma awareness background? Because it is so tantamount to how our patients are functioning.
Yes.
So the difference is I am not a mental health practitioner or therapist when I'm working with my patients. I am there to work on their connective tissue function and on them as a whole person trying to get back to their previous level of function, or the best level of function that we can get them to.
Great.
I'm not their counselor, I'm not their best friend. It can get really, especially when the patient shares something that may be part of our garden. If anyone has read Come As You Are, having that garden aspect of there's things that I like in my background, things that I don't, and there's, uprooting them. A lot of times patients can trigger for us our own issues, and then that can create poor boundaries or relationships that get a little bit less functional. They need to be supportive but have some rules in them between the patient and practitioner. I am a physical therapist first and foremost, and I am incredibly supportive of my patients in any way that I can for my scope. And I will always be looking on how can I build my patients' army, whether with professionals, paraprofessionals, friends, family, providing education with partners, friends, whoever is part of that person's community and helping them get better. Yeah, I am not a therapist. I am not practicing as a mental health practitioner. But if my awareness and my knowing of what to expect from the patient on my table, if that helps them kind of process on their own individually, like a good home exercise program or self-care program, that is completely fine and appropriate. My goal is not to create that trauma processing. My goal is to allow for their physiological reaction and their physiology to improve while they're with me.
So in your course, it's a 2-day course, Lauren, what are some of the skills, what are some of the tools that physios are going to leave your course knowing?
So trauma-informed care is huge, knowing what triggers me, and it's what's difficult in this class is it's incredibly triggering for everyone. So knowing oneself, one's cultural background can be really important in how, we all have judgments that we give to others. So knowing what my preconceptions might be, what my cultural background is, perhaps what my garden is for, is in Come As You Are, where there's a sexual garden of what has been planted there prior. So one's experience, so it's difficult because this course can be triggering, but knowing I have a TA that's there to kind of help and bring and kind of have that plan. But so there's triggering that may be in the moment or even later. There's big reactions that are experienced and that are good to be experienced. Just like when a patient has a strong reaction on their table, it may be very difficult for everyone, but it's actually a very positive thing because it's better than that freezing or that dissociation.
Sure.
If the physical therapists are able to, getting back, sorry, I just went off the tracks a little bit. So getting back to the course, the physical therapist, I want them to explore maybe what their biases and their background is. Then to look up what we go through, and we look up mandated reporting, legal aspects, different state to state, or possibly country aspects of what needs to be done in a legal sense. Because what is true in Illinois may not be pertinent. Well, it for sure isn't pertinent in Indiana. So knowing who the resources are on a national, state, local level. The anatomy and physiology of trauma is huge. That is a really big part of this course, what to expect with reactions, especially when you have that dorsal vagus parasympathetic running the show in autonomics. We also go through self-care. We'll be starting actually with the secondary trauma this session, because we did that at the end of the last course, and we actually needed self-care to begin with, because again, this is very difficult. There is a group dynamic that can occur within every situation. So secondary trauma, compassion fatigue, self-care, good boundaries, that's for the PT. Then the autonomic nervous system, how to process, how to notice how someone is processing trauma. And then also just coming up with safety plans, exploring scenarios of the patient while they're in the treatment.
Fantastic. And then, integrating that into plans of care as well. Do you find tools like mindfulness or yoga or breath work, do you find you're using those as part of your actual treatment strategies with this patient population?
We do. We will, call it diaphragmatic breathing. We'll work on, it's in yoga, it's Ujjayi breath, but diaphragmatic breathing for in my notes. There's Tai Chi energy work that can be explored with muscle patterning. There is progressive relaxation. Actually, I just found a really great RCT on progressive relaxation versus exercise for empowerment in oncology patients, and progressive relaxation beat out exercise, which was pretty interesting.
Wow.
Then I think the three biggest things to take is just the initial response of having three nice little mantras of, I believe you, you are not alone, and you have choices. So even just having always like those three things where when you have, when it's really hitting the ceiling and the fan, and it's getting really tough, you have like, okay, scene safety is always number one. But we're usually pretty safe in our own treatment areas. It's the patient who feels very out of control. Just letting them know you are not alone. I believe you, and you have choices that you can do.
Well, I think it's such a topic of the moment as well. In the context of the Me Too movement, and not just from a pelvic health, but I think from a broader societal level as well. This is really important work. Where can people find information about the course? Do you have any upcoming dates that you could share with us?
So we're going to be teaching out at Johns Hopkins the weekend before Halloween. So it should be a nice weekend in the fall there in Maryland. And then in New Jersey Atlanta or New Jersey next spring. Those dates have not been finalized yet. So we do have an East Coast offering coming in the spring.
So if folks go to herman&wallace.com, they'll be able to find all the information about where the courses are and how to sign up. The links will be there.
Absolutely.
Perfect. Lauren, thank you so much. That was really, really informative and thought-provoking. And I think probably this course should be mandatory for everybody working in pelvic. I think for everybody working in patient care, or dealing with human beings on any sort of a level. So I want to thank you very much for sharing your wealth of wisdom with us, and hopefully I'll get to take your course myself someday.
Oh, that would be lovely. Look forward to it.
My pleasure. Thanks, Lauren.